the topic given was to think about it and think many times to find holistically, when we are caring about head and neck cancer patients. So what I've done is, one is that we can't take all kind of things what we do in head and neck cancer. Restricted myself to systemic therapy, so I'll be talking about that, what we have done there in that area. And second part, I need to say that this oration, sure, there are many people, and at the end you will see those acknowledgements. But especially if you would have called there are three people you would have called, they would have given the same, told the same thing, you would have got the same oration. And the other two people apart from me, one is here, Dr. Vijay, and other is Dr. Vanita. So either of them, you can say that it is on behalf of these two people, I am saying this. And obviously there are many more people who have contributed. But if there were not these, two more people which I suggested, all the work what you have seen or I'll be showing would not have been possible. And again, I repeat, you would have called either these three of us and you would have got the same talk. So starting with the first slide. So what I'll be doing is I'll talking about what we have tried to find solution in head and neck cancer when you give chemoradiation, because you treat patients with head and neck cancer with chemoradiation. So what we did in that, how did we use our issues in the clinic to integrate neoadjuvant chemotherapy in head and neck cancer and had a solution for our patients. And third, we have a huge number of palliative systemic therapy patients where you don't have any other choice, and we do struggle to find out which treatment works here. We do know, we talk about it, what kind of drug is available and what we tried. Starting with the first one. This is McKenzie meta-analysis. Everyone knows whenever you talk about systemic therapy, you can't get away with it. What it suggests, if you give chemotherapy with radiotherapy, it improves survival of the patient. And that is here what 8% what you're looking for. And you have to give cisplatinum, and you have to give cisplatinum 3 weekly. So site-wise, it looks like whatever you give, it works. So it is an important treatment. So today you can't get away with chemoradiation in head and neck cancer, both setting, definitive setting and post-surgery. Now in cisplatinum eligible patient, this is a challenge. If you give 3 weekly cisplatinum, almost half the patient, it is tough to complete the treatment, and 1/3, they're not eligible for it. And what we found, this was led by Dr. Sarmani Ghosh, Laskar at Tata Hospital, that if you give weekly cisplatinum, that is 30 milligram per meter square of cisplatinum, with radiotherapy, it works. And as compared to radiotherapy, you add life to the patient. So giving cisplatinum, if you're not able to give 100 milligram, you give 30 milligram per meter square, relatively easy in the clinic, not required, so not so resource incentive. It works for the patient in this setting. What it did, it also led to, for a study, again led by Dr. Sarmani Ghosh Laskar, in adjuvant setting. You did surgery, and then after surgery, you want to give patients radiotherapy plus chemotherapy. This is a 3-arm study. Till this time, we were obsessed with 3-arm study. You saw this 3-arm study here. You have seen 3-arm study here. And what it showed, that if you have a high-risk patient in Indian population, if you give them cisplatinum, again 30 milligram per meter square, as compared to radiotherapy, you add life to the patient. The 5-year overall survival is better, and giving only radiotherapy or altered fraction radiotherapy is not good enough in our population, also suggesting that it is important. And if you can't give 100 milligram per meter square, 30 milligram per meter square is an alternative. So you have again data for those a subgroup of the patient, that is T3, T4 with N2, N3, suggesting the same, that giving them chemoradiation with 30 milligram per meter square of cisplatinum works. This was always a question in head and neck cancer, that if you give chemoradiation, you have a study with 100 milligram per meter square. You have a separate study. We can talk about how much powered it was, that 30 milligram per meter square, and that also works. You have a bit of a question regarding that. Did we design it good? That's fine. But 100 milligram works, and 30 milligram data is also there. It may work. So next question was that, is 30 milligram per meter square is as good as 100 milligram per meter square? This is a randomized trial done at our center, led by Dr. Vanita. And it was a non-inferiority trial to suggest that 30 milligram per meter square is as good as 100 milligram per meter square. And this was a trial design, randomizing the patient in adjuvant and definitive setting. Both at the end of the day, we had primarily the patients who were in adjuvant setting. And what it showed, that it appears as far as the locoregional failure is concerned, locoregional failure is far higher in patients who has got 30 milligram per meter square of cisplatin plus radiotherapy as compared to 100 milligram per meter square of cisplatin in this setting, suggesting that for locoregional failure, 30 milligram per meter square of cisplatin may be not good enough. Showing the same, that we also tried to analyze. What we did is say, if you give 30 milligram per meter square of cisplatin, maybe we are not giving the good amount of dose. So we took the patient who received 200 milligram per meter square of cisplatin in both the arms and then tried to compare, and it appeared the same, that 30 milligram per meter square of cisplatin is not as good as 100 milligram per meter square of cisplatin as far as the locoregional control is concerned. But it does appear that progression-free survival and overall survival remains similar. A bit reassuring that in case if you are using 30 milligram per meter square of cisplatin in that setting, but with the data that locoregional control may not be good enough. Subsequently, another trial which was done by Dr. Atul Sharma, he is the senior consultant and now HOD at AIIMS. He compared 40 milligram per meter square of cisplatin to 100 milligram per meter square of cisplatin in definitive setting, not in adjuvant setting. And these were the trial data, and what it suggested that 40 milligram per meter square cisplatin in definitive setting looks to be as good as 100 milligram per meter square of cisplatin in definitive setting in head and neck cancer. So what we can conclude with this, all the data what we have, and all this data I showed you is from India, and majority of them from Tata Hospital, that 30 milligram per meter square is not better, not as good as 100 milligram per meter square of cisplatin. 30 milligram per meter square is inferior to locoregional control in head and neck cancer as compared to 100 milligram per meter square of cisplatin. 30 milligram is better than none. If you're not giving anything, only RT, then 30 milligram may be better. And 40 milligram per meter square looks to be similar to 100 milligram per meter square of cisplatin in head and neck cancer. Now that gives you the data to use in the clinic. 100 milligram, go ahead, give it. If you can't, 40 looks like good enough. If you're not able to give 40, 30, you have data to use it in the similar setting. Now we had the next question, can we make it better? Can we are using weekly cisplatin plus radiotherapy, and we know that whatever data I showed, we have seen that you do have a huge number of patients, and that is almost more than 50% of them dying after 2 years, suggesting there was a need to improve the outcome in these patients. We had the opportunity. Opportunity was that we had EGFR inhibitor antibody available in India, which was a generic antibody in that at that time. So what we did, we did a randomized study where we compared nimetuzumab plus cisplatin plus radiotherapy as compared to cisplatin plus radiotherapy in this setting. This was in definitive setting, not in adjuvant setting. And the patients were stratified for T group, N group, and the site of the tumor and technique of radiotherapy being given in this setting. This was 536 patients trial, highlighting this may be one of the largest study in this setting in head and neck cancer, which is by and large done. There are few studies which has been larger than this. What we found, that it improves progression-free survival, it improves disease-free survival, and it does improve locoregional control with hazard ratio around 0.6 to 0.7, suggesting that these are all meaningful. I also need to highlight that it did not improve overall survival statistically. So at least these 3 parameters did improve if we add this drug in this setting in head and neck cancer for these patients. We also did a subgroup analysis that was in HPV negative patients, because majority of our patients are HPV negative tumor in oropharyngeal cancer. And what we found, that in oropharyngeal cancer, if you're giving nimetuzumab plus cisplatin plus radiotherapy as compared to cisplatin plus radiotherapy, then it does improve overall survival, highlighting that our problem, if you have a drug which is an Indian drug, you add to it, it adds a life to the patient in this specific group of patients. We also did analyze the same data for what happens to our patients for salvage surgery, because traditionally we think that you do have head and neck cancer patient, you do chemoradiation. If the disease doesn't go away, all of them we do salvage surgery. First of all, that is not true, and that we should keep in mind. Our patients, after taking this treatment for months altogether, are they willing for salvage surgery or not? And if they are not willing, what happens to them? And what this data suggests? This data was not salvage surgery versus no salvage surgery. These were the patients who were fit for salvage surgery. They should have got salvage surgery. And we divided the patient who went for it and patients who refused it, where they should have required it. And what it suggests, that if you don't do salvage surgery in the patient when you are giving chemoradiation, then you may have an inferior outcome. Highlighting that salvage surgery as a part of organ preservation should be part of your, when you're planning the treatment for the patient in head and neck cancer. If you don't do it, you may end up having inferior results for these patients, if salvage surgery where they require, if you're not able to deliver. So nimetuzumab with weekly cisplatin is an option for treatment for locally advanced head and neck cancer with radiotherapy. That was our conclusion in the when we presented this data in as an oral presentation in ASCO, and also in the publication in Cancer. And this is also part of NCG guideline as one of the standard treatment available for these patients. Subsequently, we do have a good number of patients who are cisplatin ineligible, almost 1/3 of them, if you take the data which is available, and it may turn out to be as high as around 40% or more if you take 100 milligram per meter square of cisplatin as standard of care. Suggesting, what do you do with them in your clinic? What do we do in the clinic? We randomly either don't give any chemotherapy, or we give one of those chemotherapy which is not cisplatin or cetuximab, but again highlighting, none of them has ever been explored in this setting exclusively. We give this based on that they are not kidney toxic. But this led to for us a randomized trial, which was comparing radiotherapy, which is what we do by and large, compared to radiotherapy plus docetaxel, and docetaxel dose was 15 milligram per meter square in this setting weekly till we gave radiotherapy in these patients. This was the oral presentation in ASCO this year, and this was the trial design, a simple design comparing radiotherapy versus radiotherapy plus chemotherapy. Chemotherapy was docetaxel, 15 milligram per meter square. I don't have to say this cost is, this will cost patient maybe a few thousand rupees, 2,000, 3,000 rupees for the whole chemotherapy. I'm not talking about the supportive care required for the patient. And what it suggested, that if we do this, it does improve life of the patient. So it does add life to the patient. So if you have a cisplatin ineligible patient, and in that patient, if you give radiotherapy plus docetaxel, and as compared to radiotherapy, it adds life to the patient if docetaxel is added, and with a very minimal increase in the cost as far as the chemotherapy is concerned in these patients. This is the only randomized trial except for immunotherapy, which is a failed trial in this setting. So for cisplatin ineligible trial, there's no other randomized trial which is positive, and there's only one randomized trial which has ever been done. Suggesting again, for our own patient, we can develop treatment which can be holistic, which can be less cost, and which can be accessible to them in this setting. Subsequently, we do know that we, by and large, in case people who follow head and neck cancer, that we are fairly gung-ho about metronomic chemotherapy, and we have explored in many settings. And this was another area we did explore, and that's why we keep highlighting that be careful about when you want to extrapolate data from one place to other. So what we did, if you have a patient who received chemoradiotherapy, or they failed after chemoradiotherapy and surgery, and again you have done surgery. Now these patients, they fail very early. If they are not fit for radiotherapy, again, that is re-irradiation. So what we did, we randomized them between metronomic chemotherapy versus nothing. And what it suggested, metronomic chemotherapy not only doesn't work, it is potentially harmful. Highlighting that in the clinic, if you're using something is not so costly, you're using in one setting, don't simply extrapolate it, be careful it. You have to prove in other setting that it works. And this got also validated in another trial, which was presented in this ASCO this time, suggesting that again in adjuvant setting, where you don't have a disease, if you give metronomic chemotherapy of celecoxib and methotrexate, it not only doesn't work, it may be harmful to the patient. We do have lots of patients in head and neck cancer, especially oral cavity, which is large. And which is large means it is potentially not resectable. I'll come to those patients and I'll show you some pictures. And then coming to what are resectable in oral cavity cancer. This is a bit of a gray area, and showing that when this was a survey done, people have various ideas about what should be considered resectable in oral cavity cancer. And yes, in our clinic, we get all kind of patients like this, and which are considered technically unresectable, that if you don't do anything, these are the patients who will go for radiotherapy. And I'll show you, if you send for radiotherapy, what happens to these patients. Usually the average life for this patient is 7-8 months odd. So what we did in this setting, and this is a major problem for our country, these patients. So what we did, we used an approach, can we downstage them? And after downstaging them, can we do the surgery to these patients? Because we do know in oral cavity cancer patients, surgery is one of the primary treatment, and you have to put these patients to the knife if possible. So we did give neoadjuvant chemotherapy. We took these patients, first defined what are the patients whom we call technically unresectable. These are the 4 criteria we got through the consensus from our surgical oncology colleague, which was published earlier. And subsequently, the paper which we published in oral oncology suggested that if you give patient neoadjuvant chemotherapy, 40% of the patient you will do surgery in them, and out of those, half of the patient will be long-term survival. Remember, if you have not done it, then the average life of this patient will be around 7-8 months. So this way, there was a solution for our patient who are technically unresectable. There are big tumor, otherwise going for palliative radiotherapy in this setting. When we developed this concept, this led to many of the questions. And I do understand that when you develop a newer concept, we have many other questions. What happens to margin? So we did this study to suggest that, yes, the margin positivity doesn't increase. There was an issue regarding what happens to post-op complication in this setting. You are giving another treatment here. This was a study suggesting that post-op complication doesn't increase if you give neoadjuvant chemotherapy in this setting. Then there was the issue, what happens to locoregional failure in this setting? This is not our data. These are the extra data. We have our own data also suggesting that if you give neoadjuvant chemotherapy in these oral cavity cancer patient, that doesn't lead to increase in locoregional failure. Subsequently, we use this concept regarding, we know that we do larynx preservation. Can we do mandible preservation? And this was our mandible preservation study, which again highlighted that locoregional failure in the revised margin, there is no increase in locoregional failure, highlighting that, yes, using this approach is possible and safer in these patients. Do we have a comparison if you don't use this approach? So there are people who think that, yes, anyway, we can resect any of the patient of these coming. So there are few surgeons who thinks it, and we got their data. They presented this data, highlighting that almost 1/3 of the patient, you will have a close or positive margin. You also presented, this is the data by Dr. Jatin Shah, who is supposed to be one of the pioneer in head and neck cancer surgery, suggesting that T4 tumor, you take all of them, then 45% of the patient will have the positive margin. And in our study, the positive margin rate was around 3%, suggesting that if you use this approach, then yes, your significant proportion of patient will benefit. Yes, there was another data from one of our Indian surgical colleague who thinks that one can resect any tumor. And I'll say, look to the last column, which is there. The median survival of this patient were 6 months, 8 months odd if you use this approach. So that if you want to resect any tumor, a big tumor in the oral cavity cancer without selecting it, then what you're doing is primarily a palliative surgery. And then it will become stuff that really you want to do those kind of surgery in these patients. So select, not only making them operable, because the margin will be positive in this patient, and selecting and operating allows you to operate around 50% odd patients and allows you the 50% of those patients to be long-term survival in this setting. We also use this approach. We develop in resectable tumor to see that can we preserve organ in these patients or not. We know that for overall survival, there are 2 trials. In oral cavity cancer for neoadjuvant chemotherapy, it is negative. And this was our approach, which was led by Dr. Devendra Chaukar, for patients where the tumor was next to mandible, but for this, you have to resect the mandible. That is segmental resection to be done. What we did, we randomized a neoadjuvant chemotherapy versus upfront surgery. So all went for segmental resection, and you gave those half of the patient neoadjuvant chemotherapy. And what we found, in half of the patient, we are able to save the mandible for these patients in this setting. In the long-term follow-up, it suggests that you don't have an inferior either overall survival or progression-free survival in these settings, suggesting that it is safer with a similar or better survival or better PFS or similar PFS. One can preserve half of the mandible in these patients with this approach. We also have done a randomized trial in technically unresectable patient, 2 drug versus 3 drug. Is the 3 drug better than 2 drug? Presented in ASCO this time, 490 odd patients. It appears that 3 drug, that is DCF, what we call, this is the lingo used for these 3 drug, may be better than 2 drug, that is docetaxel cisplatin, and it appears you have absolute survival benefit around 5% with increased toxicity. So that with this data, people can use in the clinic that which drug they want to, or which drug combination they want to use in the clinic for technically unresectable patient when they want to use neoadjuvant chemotherapy. Coming to palliative systemic therapy in head and neck cancer, we had the study regarding what patient wants, and it appears that 1/3 of the patient wants only improvement in symptom, 1/3 of the patient wants improvement in the life only, that is added life, but 1/3 they want combination of both, suggesting that patient wants various kind of things in the clinic when we want to use this drug in this setting. You also have patients having distress, and we were trying to see that we don't have a psychiatrist or psychologist everywhere available, especially in academic center and the government center. So we said, can the treating doctor intervene and we have a distress being removed? And what it appears, if the treating doctor also talks and you don't have psychiatrist in your clinic or psychologist in your clinic, then 2/3 of the patient benefits, and there the distress level goes down, suggesting that this is one of the interventions one can do in the clinic. What are the systemic therapy available? You have systemic therapy, what we call standard, which is there in NCCN. It is cetuximab plus 5-FU cisplatin, and only 1 to 2% of our patient can afford it, suggesting for 98% of the patient, this is not a standard treatment in this setting. And we also did a study regarding this, which was an oral presentation by one of our residents, Dr. Ravi Krishna, in the ASCO this year, suggesting that immunotherapy, which is again one of the standard of care in this setting, only 3% of the patient can take it, suggesting for 97% of the patient, again, immunotherapy, which is supposed to be standard of care in this setting, is not available for our patient. It's again, do we have solution for our patient in this setting? So first of the solution we tried to develop the metronomic chemotherapy, that is celecoxib and methotrexate, which is around 100 or 200 rupees per month cost of the patient. This was phase 2 randomized studies comparing IV chemotherapy cisplatin versus metronomic chemotherapy, that is oral tablet, and it suggested that it controls the disease better and it leads to overall survival benefit. This led to our phase 3 randomized trial, which was more than 400 patients, which randomized between oral metronomic chemotherapy versus cisplatin, that is IV chemotherapy. And it suggested that if we do this, this was Nandini's presentation in ASCO last year, that was a oral presentation, that it adds life to the patient if we give oral metronomic chemotherapy as compared to IV cisplatin in this setting. And it is safer, it is easy to use, and it also improves overall quality of life. We subsequently led to development of better metronomic chemotherapy. We used to use 2 drug combination chemotherapy. Then in that setting, only 10 to 15% patient response. So we're looking for, can we develop further chemotherapy in this setting, which increases more patients, increases the number of patients who respond to the treatment. This was called triple metronomic chemotherapy. We added erlotinib to methotrexate and celecoxib. This was a phase 1, phase 2 oblique study, suggesting that in palliative risk, in the cisplatin resistant patient, 43% of the patient, they responded, highlighting that yes, and if you take this response, this was better than what we have seen with alone with immunotherapy. And this led to subsequently, this was the PFS and OS data, and also suggesting that majority of the patient, there was improvement in the symptom. This data led to development of low dose immunotherapy in this setting. We all know that if you use full dose immunotherapy, then only 3% of our population can take it, and the cost of the treatment is around 2.5 lakh per month. So what we tried to do, we said we took triple metronomic chemotherapy, which costs around 2,000 to 3,000 rupees. We reduced the dose of nivolumab, which is an immunotherapy, by 1/10. We used 20 milligram flat dose combined with triple metronomic chemotherapy and compared this with triple metronomic chemotherapy. What was the basis for it? The basis for it was that if we use 20 milligram of nivolumab, then that leads to 70-80% occupation of the receptors on the lymphocytes, which is good enough. And if you keep increasing the dose beyond that, the increase in receptor occupancy by these drugs doesn't increase, highlighting that there was a basis for it that 20 milligram could be enough in this setting. We used this data, which was available by a pharmacokinetic study, to see that does it work in the clinic. But again, reminding, this was not nivolumab 1/10 dose alone. It was in combination with triple metronomic chemotherapy. These were just some representative picture for the patient, how they responded to the treatment. But this was the randomized trial data for response rate. The response rate increased from 45% to around 49% to 65% in this setting if you use triple metronomic chemotherapy plus immunotherapy as compared to only chemotherapy. And also it led to survival benefit for the patient if this low dose immunotherapy was used, which was 20,000 rupees per month cost rather than 2.5 lakh rupees per month cost for in this setting. So in conclusion, I'll suggest, as far as the holistic development of systemic therapy is concerned, from our side, systemic therapy improves survival in adjuvant setting, so it is important. And we do have Indian data and Indian solutions in this setting one can use in the clinic. Systemic therapy helps select patient for surgery in technically unresectable head and neck cancer and adds life to the patient. So if you have a big oral cavity tumor, don't leave them only for palliative radiotherapy. Half of them you can change them to surgery, and though half of the patient can undergo surgery, again, half of them can be long-term survival. Systemic therapy improves survival and also leads to good palliation in advanced stage tumor. And in that setting, if you are able to give full dose immunotherapy, please go ahead, do it. If you are able to give cetuximab, please go ahead, do it. But those 97-98% of the patients who are not, triple metronomic chemotherapy with 20 milligram nivolumab does a good job. And this is a very good alternative for our patient in that setting. Most important, what we did and why we did, and what you saw, that we always tried to look beyond NCCN. You said NCCN is only one standard. Not necessarily. If the same what we are looking in NCCN, we are not able to give it to 97% or 98% of our patients, then they need to have a different solution. The solution, what is there in New York, not necessarily there need to be in Mumbai. What is there in Mumbai, not necessarily need to be in Varanasi. I'm using that name because these are the places where we have a TMH center. And what is there in Varanasi, not necessarily that needs to be in Muzaffarpur, because the example and the patients, what they go through at different places, it is different. So these places require a different solution. And this is what we try to find out and we try to give to our patients. What we did at every place, we assured that every solution and the result, what we get, very next day we have implemented in our clinic. We have not left only for having this question to be answered, having a publication, and not implementing. We have got the data for nivolumab and triple metronomic chemotherapy. You can go and check in our clinic, it is offered. Triple metronomic chemotherapy data came in the phase 1, phase 2, that was being offered to the patient very next day. You had data for weekly cisplatin being inferior, we changed from 30 milligram to 40 milligram per meter square. For neoadjuvant chemotherapy, again, we used the data in the clinic, highlighting that if we did something, we use the data in the clinic to providing solution to our patient. Primarily because as a group, we try to look beyond what is there in NCCN. And as I suggested at the starting, there are a whole lot of people who have worked in this area. You can see are some of the residents, our coordinators, some of the residents can relate with many of the coordinators. You can see some of the residents sitting here who has been part of this. If the pictures are not there, my apology. I don't have picture for a whole batch. So I don't know, from my side, these are representative picture. And these are the people who are PhD student working in the lab. I didn't show the lab work, what we have done. Thoda zyada lamba ho jayega and boring bhi. So those people do work in the lab. Some next time you got a chance, I'll be showing you some lab work, what we did. And these are my faculty colleagues. And absolutely without that, nothing what I showed would have been possible. And I took the two names. I'll again take the two names, Dr. Vanitha Narona and Dr. Vijay Patil. And absolutely, they would have presented the same thing. You wouldn't have anything different. But apart from that, Dr. Amit Dutt, Dr. Amit Joshi, Nandini. Now I have Ajay with me. That picture is not there. Then we have Pratik and Dr. Anuradha from the lab. This is a lab which we have, and I always keep saying, if you find this like beti padhao, beti bachao, you see all of them being female. This is a good representation of that. Bichara, there is one male aberration here, but again, a wonderful lab. And the three people I need to be indebted. My teacher, Dr. Bapsi, where I did DM from, very kind lady, very nice with me. And again, when you do a whole lot of work, you require support of your bosses around who needs to be kind to you, because you will have issues where they need to be there for you. And Dr. Banavali, my head of department earlier, now my boss as academic director, and Dr. Badwe sir, I'm sure all of you know, a very kind-hearted person and support us fully. Whole lot of acknowledgement to my person who I collaborate with, my family, and thank you so much.
Thank you. Thank you, sir, for great oration. I just request all of you, please stand up and give your big hand to sir for this great oration. Thank you. And who other than Kumar Prabhash can justify this kind of oration for the stalwart of Advani sir? And Advani sir, who always being there with me right from first IVCC to till date, and he always shows their blessings hand on me and show the blessings to us for this all kind of organizing meetings. Sir, I just request you for your word of wisdom. Sir, please.